Okay, thank you, Mardell. Good afternoon. I'm Deb Smith, Treasurer for the ACHA Board of Regents. Welcome to today's Town Hall on Health Equity. I would like to thank our speaker on the panel and also the continuing Competency Committee for coordinating this program. Before I turn the program over to Mardell, I want to make sure that you all are aware that registration is open for this year's Summer Leadership Symposium. They'll be held in Denver on Friday through Sunday, July 26th through 28th. The title of this year's program is Health and Healthcare in an Artificial Intelligent World, and we'll focus on how new technologies are affecting our communities and how our institutions will harness these technologies to impact health outcomes. Please see the ACHA website to register, and just a reminder, space is limited. So now I'll turn the program over to Mardell. Thank you.
All right, thank you everyone for joining us. This event is the second Hot Topics event that we've produced in the last year, and we think this is going to be an excellent experience. I should mention that we're in the process of selecting what next year's topic will be, so if you have some ideas, please share them with one of the people that's on the committee, and that's Thing, Eddington, Dan, Jody, and myself. If you're interested in CU credits, a link for registration will be provided at the very end of this panel discussion, so look for that link in the chat. And you'll be able to participate and ask questions through the chat, which we set some time at the end, so we'll be able to go through that list and get to your questions, assuming that we have the time to get to all of them. The way it's going to be organized is I'm going to, all three of these speakers have really remarkable and impressive accomplishments associated with them. I have asked them, however, to share individually something about who they are, what they do, and potentially tell us at what point in your career you became interested in proactively engaging in this topic of the topics of health equity and diversity, DEI overall. So I would start with, why don't you go, Tammy? Tell us about yourself and why you're here.
Thanks, Mardell. Thank you for everyone. We are honored to have this opportunity. I am Tammy Thompson. I'm based in North Carolina, and I serve in my primary role as the Director of Experience Engagement, Education, and Design for a large health system of 9 hospitals and close to 200 clinics. I serve in a role that has responsibility for patient education, patient and family advisory. I'm so sorry. Was I muted the entire time? Okay, sorry. So
just for a second.
Okay, got it. So I'm responsible for patient education for our system, patient and family advisory councils, and also experience design, which is a very interesting and fun role. And I also serve as an adjunct professor at an HBCU in North Carolina, as well as what most of my friends here on the line might know me as the president for the Institute for Patient-Centered Design. I became immersed in health equity work probably about 5 years ago. And it stemmed from the needs that I saw at the health system where I worked at the time with certain patient populations. Shortly after that, I had the wonderful opportunity to join the Robert Wood Johnson Foundation's Culture of Health Leaders program, which is the most amazing fellowship that I could even ever imagine. And they started by giving us a deep dive into health equity, diversity, equity, and inclusion, education, and the history of inequities in this country. So it was a real eye-opener for me as a designer and as a leader, and it has been a wonderful opportunity to build on the body of work that we started at in the Culture of Health Leaders program as we continue our work in the community.
Thank you. Why don't you go next, Taft?
Good afternoon, everyone. Thank you, Mardell and everyone, for having us. I am Taft Cleveland. I am a healthcare planner and an urban planner in our Chicago office at SmithGroup. I have about 20 years experience in working on all types of healthcare projects. Recently, I was nominated to be co-chair of our Justice, Equity, Diversity, and Inclusion team that's part of our platform of engaging our 1,400 experts here at SmithGroup in our 20 offices to look at how we can engage not only our clients, but ourselves as servants of our communities to design a better future through design justice and looking at a number of initiatives to help us really see the impact as designers, architects, and engineers that we have in our profession. When I think about my career, when I first started hearing about health equity, it probably goes back to the Black church that I attended in Detroit, Michigan, that has a social justice lens in the spirit of Dr. Martin Luther King. And it was through understanding the plight of the Black community and understanding all of the health issues, all of the things that happened in our neighborhoods that kind of gave me a background of wondering how could I, as a designer, help the communities that I live, work, and play in. And it was when I had an opportunity to design the first orthopedic hospital, along with an organization in West Africa, Accra, Ghana, that was looking at the needs of the patients from all over the world who have all of these different S-shaped spines, who needed care but couldn't afford it. And so that was like the first time that it really hit me that as a designer, you can really do some important work to help humanity. And so for the past 20 years, I have tried to live up to those expectations that was given to us from that project.
Thank you. And Troy, would you like to join in?
Hi, everybody. Firstly, thank you so much to Mardell and Dan and Deb and Thane and the entire committee for including me in this. My name is Troy Savage. I am a manager of strategic projects and innovation at Mazzetti. We are engineering and sustainability consultancy. And then I'm also serving as the executive director of an organization called the Sextant Foundation, which was founded by Walt Vernon, who is the CEO of Mazzetti. So Sextant can really be categorized as doing two things. So number one, we do clean energy and development projects and a little bit of disaster relief in low resource settings. And then number two, we spark innovation at the intersection of healthcare design and practice by creating reimagining workshops. So how did I come to the health equity? You know, in some senses, I looked at that question or was reminded of that question a moment ago and said to myself, oh, I'm not sure if I had a sparking moment where that happened. And I thought back to myself for a moment and realized that there's a couple of key ideas or concepts that for me kind of embed the concept of health equity in everything I do. So one, I have a faith background or a religious background, and there's a concept in my religious tradition that is sometimes understated, but really says, I was hungry and you fed me, I was naked and you clothed me. When did we do that to you? He said, when you did that unto the least of these, you did it unto me.
You build that priority matrix.
And that
What's priorities? We just help.
Please, please turn off your, thank you. Go ahead. I'm sorry, Troy.
Oh, no problem. So that idea or context, and I don't think you need to have a religious background to have that idea or context, by the way. I have a religious background. But that idea is the idea that in my case, that God can be kind of incarnate in somebody. And if you're thinking about who God might be incarnate in, you should think about kind of who is at the margins of whatever you're doing. And the idea of health equity is to think about how health looks at the margins and making sure that's what's happening at the margin is happening for everybody. So that concept for me is kind of a lifelong concept. And so when I ran into the idea of health equity, I realized that was a way of actualizing kind of that background in the world and specifically around health. Now, obviously, health is really important, and when we think about health, I think what we're really thinking about is how to ensure that people who need something get it. And so, if that's true, we want health to be equitable. So how that plays out in my day-to-day career is still unfolding. I like to think that I'm always a voice for health equity, even if not explicitly saying so, because that's kind of the centering idea for me. In explicit ways, it's about giving people an opportunity to innovate in ways that might enhance health equity, for not reminding them subtly or intentionally that what we are looking for and what we are looking to design is for the what I call the least of these from my religious tradition, but simply those who are at the margins. And so I try, and sometimes fail, but try to keep that as an ethos in everything I do as I help others to innovate.
Right. Thank you, Troy. And while you have led to that topic of actually what is health equity, I'd like to give Tammy the chance to answer that, and then I'll follow up with Taft, and you can talk about JEDI as well. So, what is health equity, Tammy?
Well, in my context at the hospital, we define health equity as an opportunity to realize the desired outcomes anyone might have in their health and well-being. I specifically look at the social determinants of health as a way to help, I suppose, as a framework for health equity, to help me to wrap my mind around the areas of opportunity in health equity and the areas in terms of metrics where we might find those opportunities in our data. It is allowing any patient, any community member to experience the health outcomes they desire, to realize their optimal health in any situation, regardless of barriers they may see in their day-to-day lives that relate to race, gender, and you name it. We know the protected categories. So we look at that and determine whether or not we are able to deliver, or are we currently delivering equitable care.
Thank you. And Taft, do you want to join in this? And you can talk about health equity, but also DI and JEDI, which you've spoken about before.
Thank you, Mardell. This is, when I think of health equity, I have to go back to a quote that Dr. Martin Luther King gave in Chicago back in 1966, where he said that all of the forms of inequality, injustice in health is the most shocking and the most inhuman because it often leads to physical death. And so when I think of health equity, I think of one, this is nothing new, that we've been talking about this for generations. And so how can you look at health from a standpoint of limiting the number of deaths? And we can see through all types of data, whether it's looking at zip codes or even in the built environment, how this has been an impact in how people have lived and whose lives have been cut short because they do not have access. And when I look through the lens of, EDI and JEDI, I often ask this question that EDI seeks to ask who, and that is who is omitted, who needs to be included in the conversation, and you have more of an internal focus where you're looking at, for Tammy's in the hospital, she's looking at, who is missing from a doctor standpoint or practitioner, who on staff that they need to have to represent the communities that they serve. Jedi, on the other end, seeks to ask why. And so whether that's why are certain groups of people historically disenfranchised, it's more of an external focus. It's on the built environment and trying to get to the root of why things are the way they are. Health equity is kind of a summation of both of those in that it asks when. And it's looking at when will everyone have the same opportunity, the same access that is fair and just to attain the highest level of health. And so when you look at those three, I look at health equity as being more like an onion, that the more you peel back all of the injustices, all of the backlash that we're seeing with DEI or EDI, where hospitals and other Fortune 500 companies since George Floyd are now reversing the trend and trying to get rid of those programs until you peel all the way back this painful process until you get to the core, which is justice.
And so JEDI stands for?
Justice, equity, diversity, inclusion. The difference between JEDI and EDI is the justice part, and the justice part is where you can truly achieve health equity.
Thank you. So the next question, getting down to actual application, how might the physical environment impact health equity and DEI? And I'm going to ask you maybe to give an example or two. So let me go back to you, Troy. You're on mute right now.
I was the first one to have that issue. Welcome to the Zoom webinar, everybody. So I think the question was, how might the physical environment impact health equity and DEI? It's funny because in many cases it is a difficult question, right? And when we think about it, I'm an engineer by training, and we can often think to ourselves, oh well, we don't have anything to do with that. I'm designing some plumbing, or I'm just designing a building. But the truth is the physical environment has everything to do with health equity. I won't get into the history of the United States, which many of you know much better than I do, and kind of the idea of redlining, where rules were created to segregate some communities rather than others. But if you think about the ways at a macro level in which communities across the country were bifurcated when highways were put in, the physical environment was changed, and you had like a community in Miami, Overtown Miami, that was a segregated but thriving Black community. The physical environment was changed, a highway was put through it, and it completely disintegrated that community, as an example. So at the macro level, you can think of kind of at a planning scale of how decisions around the physical environment can demonstrably lead to impacts in health equity, where now such communities don't have the food resources they need because there's not an economic base for them, don't have the diversity in economics or socioeconomic status that they need, all because of the physical space. So at the macro level, you can think of it that way. I think also at the micro level, or the scale that many people on the call might be designing for. You can imagine that as you are creating a design, you have a natural center in which you are thinking about that design. And when you have a center, it creates edges by definition. And the question becomes, what is the effect of what you're centering for the edges? And so for a physical space, as an example, right, does that physical space feel welcoming for those who you weren't centering, consciously or unconsciously? By the way, we all have to center something in our design. And right, does that space not feeling welcoming mean that people are less likely to go in and get care? less likely to then get a diagnostic, and therefore more likely to affect diagnostic equity, as an example. Every decision that we make, every design decision that we make has an effect, and the physical environment it affects health equity. And if we are aware of that, then we have the opportunity to think about our designs and to design for health equity, so that we can get a better outcome.
Tammy, I think that what I've heard you discuss previously is going to tie nicely with what Troy's been talking about. So do you want to build on this or expand on it?
I do, thank you. So first of all, I want to just sort of make the distinction in what I'm about to say between DEI and health equity. As a registered architect, I am among about 500 to 600 Black female architects in this country. And if you look at the numbers that we have, over 100,000 registered architects in this country, and only just over 500 are African-American female architects. Let's just let that sit with you for a moment, all right? Because that represents 0.4%, which has actually doubled since I graduated from undergrad. But doubling a fraction of a percentage is not much. We look at in total, 2% of our architects in this country are African Americans, period, but only 0.4 African American women. All right, so if we talk about DEI for a second as it relates to design firms, we know from the evidence that having more perspectives at the table will make us more innovative in our solutions. And so there is absolutely an opportunity for designers to embrace and diversify in their own firms just to become more competitive and more innovative. We would not dream of embarking upon a design project for hospitals without engaging nurses and providers and a wide variety of the roles we see in healthcare. And I would like to propose that we shouldn't even think about embarking upon a healthcare project without also engaging the wide variety of users and residents and stakeholders in the communities served by that health system. So DEI, in my opinion, plays a part not only in the health system, but as it relates to our specific audience today in design firms and in design communities. So then when we move into the physical environment and how it could impact health equity, I look at projects like there's one that I'm working on pro bono right now for a local community where we have identified a community within our county that has no primary care services available in this community. They actually now no longer even have a police station in the community. And so we are locating a building, we're actually repurposing their old police station to become a health hub that will provide access. So this goes all the way back again to the social determinants of health, and access to care being one of those, that would provide that physical space where residents in this community will have access to go when they don't have, and sometimes may not have transportation, to travel a short distance and within their community receive the care, the preventive care, the wellness care they need to support their health. So when we talk about the physical environment, it has a huge impact both on the designers of the physical environment, or from that standpoint, but also on the physical space and providing that access to care.
Thank you. Taft, I know you have this interest in food deserts associated with healthcare settings. Would you like to pick up there or head wherever you'd like? You're on mute again.
Sorry about that. I would like to comment on what Tammy was talking about and representing the communities that we serve. DEI, when I look at JEDI, the justice, again, it looks at those percentages that Tammy talked about from a Black architect woman's perspective. That's not even 1%, and looks at that as a way of engaging that community to look at ways to strategies to get that population back into the industry, starting all the way from elementary school throughout college. And it's a strategic that is purposely done. It's not accidental. It's not asking where can we find resumes, and if you can't find one, say that there's no resumes around, but it's actually doing the hard work to find that. And once you start to engage that, then you start to look at ways and solutions to solve those problems, to bring in more people of color, to be more of the architects. From the environmental impact, from a physical environment, I look at what Troy was talking about as a resident that grew up in Detroit that was hit redlined big time, even to the point where my parents' home is now in the middle of Jeffries Freeway, one of the expressway systems that Troy alluded to as far as looking at our history and what that has done to our communities. And from the physical standpoint, we know from a social determinants of health perspective that 80% of what we see when it comes to health is derived from the built environment, whereas the other 20% is with healthcare facilities. And so when I concentrate on that 80%, I have looked at every neighborhood that I lived in and looked at where do we get food, where do we live, where do we play, what are the life expectancies of those zip codes. And so when you start to look at the physical environment, you can see how those lead to solutions that lead to achieving health equity. And if we do not think that the residents, the community, and these wicked problems that we feel as designers that are outside of our comfort zone or outside of our impact, if we subject ourselves to that, we will never be able to design of what that 80% does to the community and how it impacts the buildings that we design. So my focus has been looking at the 80% and trying to figure out how can we do that in order to help the hospitals take care of what they usually take care of, which is not only the people and their staff, but to try to minimize on some of these health disparities that's impacting the 80%.
Thank you. I'm going to move on to the next question, and that's, we think about this at the very large scale, and maybe we're even thinking about in the context of what we're producing in our design firms. My question is, how can a specific individual take action to achieve health equity and DEI goals? And Troy, why don't you go ahead with that?
Sure. I think it's important to recognize that we all have agency, and that we all have the opportunity to make a difference, and especially as designers, we have that opportunity. So there's a lot I could say, but I will say that kind of in our role as designers, we're creating kind of both the physical world as well as the way that people imagine the possibilities in their world, and we're designing both. And I think that implicitly we are taught to achieve something amazing with our designs, right? We know that the design of physical space, even in healthcare, can be healing, can change things. I've heard it quoted that the design of healthcare spaces can in fact be considered a medicine. And so I think, as we're very practically speaking, I'm talking esoterically, but I want to hone this into specific design practices, right? So as we're kind of imagining ourselves as designers and imagining creating great designs in healthcare, or maybe even at a planning level, I think that we can take a pause and remind ourselves that the goal of our designs is health equity. So the goal, the object, the aim, the objective function of our design isn't to create an amazing design, although that's important. Maybe isn't even to create this this great design that is healing for some people. But the very goal of our design practice is to enhance health equity. And I think everything kind of around us can serve to detract from that goal. But if we keep that in mind, it changes how we design, it changes who we talk to, it changes how we see the social determinants of health. It changes how we see the importance of DEI and JEDI. And I think it is a very practical thing that we can do. And we can also be the perhaps awkward and uncomfortable voice, less uncomfortable than it was maybe 5 years ago, that reminds our teams in design meetings, that reminds our principals, that reminds our fellow firm owners, that reminds our clients, hey, we're making this design. How are we centering health equity as part of this design? And that is a practical and bold step that we can take internally to remind ourselves. And if we want to do even a little bit more, we can be a voice that reminds the entire teams of that every opportunity that we get. And I think when we do, we'll end up with increasingly better results.
Tammy, would you like to add something to that?
Yes, so from a DEI standpoint, how one individual could make a difference in DEI, the word inclusion is right there. And it really would be great to see each individual embrace inclusion and think about, how could I become more inclusive in my practice, in my social settings and networks, to extend and welcome other perspectives. Think about the people you mentor. And I'm guessing that everyone on this line has mentees. Think about their makeup and whether they look like someone from your family or whether they don't. And start to think about how to add and build a more diverse network of individuals. If we look, and I've mentioned this before, and some of you may have heard me say it, but if we look at our universities, particularly the universities that educate specifically in health facility design, just take a look at the history and understand how long ago it was that they actually started admitting people of color. And so I can say that in my father's generation, based on his age, if he had applied to some of these universities, he would not have received admission just due to his race. So then in my family, I become the first generation of a student eligible for admission into some of these schools. And if you think about that for a moment, think about how you discovered architecture and healthcare design. And whether it was having, friends of your parents, or someone in your family practicing architecture. And so in our history, when people of color were denied opportunities to participate in certain professions, that is why we see these numbers that I just mentioned a little bit earlier in this discussion. And so we can all stand to be more inclusive. Everyone on this line could stand to be more inclusive in diversifying perspectives in their own networks and extending opportunities to younger generations so that we could increase these numbers. And I will say this, as it relates to health equity, how might an individual make a difference? Educating themselves on the state of health equity for their clients and the populations served by their clients. Everyone in this presentation has access to the internet, and you could go and find the community health needs assessment for the area that your hospital client serves. And on that community health needs assessment, it allows us to look at data that points to obstacles, needs, barriers, and inequities in the communities served by your clients. And so that would be a great step at educating yourself so that on day one, that first design meeting, you have the tools to ask the right questions.
Thank you, Tammy and Taft.
I'm nodding my head at Tammy because that is so true. I would take a step further while you are looking at those the hospital community health needs assessments. I would actually drive around the hospital and see what's there and what's missing. Look who's walking around, look who's driving. Try to get go somewhere to eat and see what you find. See if there's any parks. And then when you start looking at health equity, you can start to develop your own program based on the needs of the assessment and what's missing from you just driving around. And if you're in a major city like Chicago and you don't have a car, just Google map and look around and see what's not there and what's there. From a DEI perspective or from a JEDI perspective, I always ask who's missing. And one of the things that I can relate to as a kid, I always heard some of the elders say, you're either on the menu or you're at the table. And when I look at health equity, everything that impacts Black people, brown people, people of color, they're on the menu. Every disparity that you can think of impacts people of color more than anyone else. And so am I on the menu or am I at the table making decisions, giving input, strategies in how to improve those conditions that I am a demographic of? And so I always, from a DEI and from a JEDI perspective, I'm always challenging myself that if we're going to be true to health equity, which is access to all, then we have to start to shift those who are on the menu to be part of the table conversation, to be included in that collaborative effort.
Taft, I will never forget you telling me how you went to a hospital with your mom, and when you left there, you were trying to find something to eat that was healthy. And a few food chains, not to mention any particular organizations, what was all that was available within a reasonable distance. So I know that's associated with your CARE project, CARE project, and there's people can reach you, I assume, to have you share your thoughts about that.
Yeah.
I'm going to now ask each of you a single question, and we thought about these in advance, sort of tailored to particular perspectives of our three panelists. And Tammy, the first one was, what questions might be asked to convey the importance of systematic and institutional support of health equity and DEI?
Thank you. So when we start talking with clients about their goals for any particular project, what we should know, and you probably already know, that healthcare clients are extremely influenced by data, as we should be. And so looking at things like, pulling data to help us understand the longest length of stay within the facility, pulling data to help us understand the frequent visits to the ED and opportunities to innovate and care in the ED, opportunities to look at certain patient populations and understand physical limitations and how we might, from a design standpoint, address those physical limitations if we understand this is, this patient population makes up majority of patients coming through in this specific area. And so asking informed questions, making people aware that you view the data and have done your homework, and then also asking questions to understand more about their goals for certain patient populations. I'm not sure how many people on the line are familiar with the new Joint Commission standards as it relates to health equity. But this is relatively new, so that when hospitals start getting their visits from Joint Commission, they are asked to identify the specific area of focus for health equity, and then talk about some of their work in those areas. So they're asked to look at, to explain to Joint Commission the data that they've pulled already to understand where are some disparities and areas of opportunity as it relates to equity, and then to describe the project and body of work around that. I believe designers could be extremely influential in that area when we educate ourselves on health equity priorities and imperatives, and start to partner with our clients to develop new solutions to make the facility accessible, to address certain needs, physical needs that various demographics might have, to break down barriers as it relates to classism within healthcare between team members and staff. So looking at, doctors and providers lounges and the exclusivity of that as it relates to other team members, and understanding how we might identify those opportunities based on the data from that specific hospital and from that specific community. So that's where I would start as it relates to questions to get the discussion started, and to emphasize the importance in your team of promoting health equity.
Thank you. Troy, the question we created in advance for you was how to implicitly or explicitly center health equity and encourage action.
Great. And I realized I might have already embedded my answer to this in a previous question. So I'll say the following. Right. So I do think that mindsets matter, and helping explicitly or implicitly lead others in how they think and conceptualize around problems and design is really important. To put that more concretely, right, being willing to think about health equity and being willing to voice it really matters. And I'm going to say something explicitly, since I'm touching on this again, and I think it might be helpful. Right, the goal of health equity, in a sense, is to give everybody the opportunity to achieve health. Right? So obviously there are differences in people's situation and in the social determinants of health, and there's differences in people in biology and in environmental considerations, but we want everybody to have a fair shake and a fair shot at health. That should be pretty uncontroversial. I think when we sometimes talk about health equity, definitely when we talk about DEI or Jedi. In this country, other perspectives get layered onto that. And when we have these types of conversations, people can bring baggage to them, but we don't have to, right? The fact of the matter is that if there is someone, whoever it is, who is lacking something, right? We as designers designing buildings or designing systems want to give them what they need in order to achieve health equity, and that doesn't have to be controversial. We don't have to tread lightly around that topic. I think we can boldly and unashamedly say that we want to center health equity in our designs. Tammy and Taft just gave you some really helpful tools and considerations to do that. Funny, I had the opportunity to lead an innovation project for an organization called Academy Health, who is the professional home of health services researchers. So researchers who are trying to understand the healthcare system, right? So how the healthcare system works, who it works for, where it works well and where it doesn't, et cetera. And, you know, that field of study is at the very least inextricably bound with the social determinants of health. And yet even there, it can be really easy to do work, but to forget kind of the ultimate goal and vision, which I've said, like, hey, center health equity, right? And so I think doing it explicitly, right, saying it out loud, taking some of the practical steps that Tammy and Taft just mentioned, like, hey, let's go see what this neighborhood looks like. Let's look at the data's, not sure if the data is out there. Let's take a look at the needs assessment in this area. Let's talk to some of the people who are there. If you want to go upstream from that, as we're looking at the needs assessment, let's identify the parts of the needs assessment that aren't being done, because the research that is being done is centered somewhere other than where it needs to be in order to achieve health equity. And reaching out, you can reach out to me, reach out to researchers, and get them to start researching those topics. Let's build networks of diverse people that we can have the conversations with and that push and expand our thinking. Because the truth is, right, all of this will very practically and demonstrably benefit health equity. So I'm repeating myself a little bit, but I think it is kind of at a macro level and at a micro level, centering health equity, and then having the conversations with people in order to continue moving.
Okay, and Taft, that leads pretty directly to the question that I was going to give you, which is, when you start a project, how do you determine who is missing from the conversation?
I was thinking about this, Mardell, and I'm just going to kind of take a few things that Tammy and Troy alluded to, and is just looking at the data. The data is so key, and just looking at the data analytics that help you understand health disparities, that give you a little bit more insight in the community health needs assessments that each health system provides. It also addresses some of those social barriers or the social determinants of health that Troy described. I go back to the exploration grant that SmithGroup had, that they have every year, and that I won the opportunity to explore what the care framework could do by looking at social determinants of health surrounding hospitals within a 15-minute walking distance. And that included just looking at it from a food injustice perspective, not even looking at transportation or economics or the built environment, but just looking at food. And just looking at that, you can see all of the disparities, and then you can start to connect those dots and see why is this community so has large numbers in cancer and hypertension and diabetes and obesity. When you look around and there's no grocery stores, there's no healthy restaurants, it's all just gas station, convenience stores, liquor stores, and there's no parks for people to run and play and to get that weight off and to live healthier. And so when you start to connect the dots as designers, then you can start to have a better understanding of who's missing from these conversations, because the people in the community can tell you what they need and what they desire. But we have to get out of our stance of being privileged and having the benefit of having this unique design perspective that we add, and being stewards of design, where we think we know everything, we don't listen to anyone, we take our own implicit bias and we apply it on people who are already experiencing harm, and our designs it just exacerbates that harm even more. And so for me, just looking at, how taking, the urban design, the planning, and even some of my, just my love for people, when I start to apply all of those lenses, you can start to determine like who are missing from those conversations. I go back to what Tammy's talking about with the C-suite and the doctors and the nurses and the practitioners, but do anyone have conversations with EVS? Anyone see why, have asked them, do they like sunlight? Because they're always in the basement and they don't have access to that. So when you walking down the hallway of a hospital, just be a more welcoming, inviting person, like Troy was saying. Be kind, be welcoming. Why don't you just ask them questions and to see how they are operating in the hospital? Because some of the same people that are experiencing these health disparities that live in the community are some of those workers that are in the hospital that people don't even acknowledge, because they're so focused on one particular demographic in the community, not realizing that they have staff that are experiencing the same trauma. So it's just trying to have a better understanding of those that are on the project that you're going to be working with, that you don't see at the table where you're designing all the time.
Thank you. I see that Dan, who's one of my team members, is asking a question about obstacles you faced. I would like to, forgive me, Dan, I'm going to ask to bring a little closure to this topic, and then if we have time to do that question, we will. So this is I'd like to think this is an optimistic perspective, an optimistic closure. And for each of you, what do you predict that the future will be for HEDI in 10 or 20 years from now? And Tammy, why don't you go ahead? Let us know what you think.
Sure. So in my experience in working with students, I am very optimistic, because what I'm learning is that the youngest generation of professionals now is very much involved in and concerned about social issues and empathetic toward others and social barriers. So I believe this generation is very inclusive, and I believe this generation believes in shaking up this sort of comfort zone. To me, the biggest barrier to health equity and diversity, equity, and inclusion would be comfort. And I know I have heard this. Tell me if you've ever heard, or think about whether you've ever heard someone say, well, race doesn't matter to me. I don't see color. That's fine in one's personal life, but in the profession, we are obligated to see color because of the fact that there are such vast disparities in that nature. And like I said, pulling the data to Taft's point and Troy's point, and investigating, doing your own research to understand those disparities forces us to see color and race and to pay attention to it, so that we can improve the future of health equity for our future clients and those stakeholders of the spaces we design.
Thank you. And Troy, in a couple of minutes, how do you see the future?
Thank you for slipping in that time, Mardell. I'm an optimist. I think the future is bright. I think today the people who are gathering the data around social determinants of health and health equity are gathering good data, are willing to call a spade, if you please, or to recognize and say what the challenges are, and are thinking upstream. So thinking not just about what the data says, but why the data says it. Why do we have a situation where there are disparities, and not assigning blame to that, but taking an action that says, oh, we can fix this. And also recognizing what might be phrased as diagnostic equity, or saying, like, hey, where are people being excluded, obviously, from the healthcare system? And more to the point, where are we putting barriers to people even getting kind of access to care, to learn that they have an issue? I think Tammy mentioned that the students are bright and care about these things. I think we're developing the tools. I think we have calls like this. I think we have leadership like Tammy and Taft are obviously providing in the space to speak these particular truths in neat ways. And I think increasingly we have the opportunity to be the change that we want to see. I'm hoping that everybody leaves this call as part of that story.
Thank you. Taft.
I'm optimistic only from the perspective that if we get ourselves out of the way, then we won't have to keep repeating this cycle of some major event happening in our lives where we have to pause and then reset. And then there's a backlash and we go back to what we did before in order to restart and realize that was wrong. We have to right the wrongs that we did not try to solve the first time. So I'm optimistic that the next generation will try to solve the problems that we refuse to do or have neglected to do. But again, if we get ourselves out of the way, I think that's when we'll be able to make some really positive change.
Right. I want to thank you all for participating in this. I will remind everyone also in the chat, you will see there is a link to get CU credit. And I'll give ACHA a moment, either Emily or Deb, if you want to say one last thing. But so appreciate the three of you coming together. And I know you've worked together in the past. Your understanding of one another make this seamless in terms of our being able to understand your perspectives, and genuinely enjoyed the opportunity to have you all with us. So Deb or Emily, do you need to say anything in closing?
I just will thank everybody for some very great discussion and information to us, and we appreciate it all. And I hope everybody has a good night. Thank you.
Good night.
Awesome.